In this video, a dissection review of the gluteal and posterior thigh regions will be presented. This work was conceived by Carlos Andrés Suarez-Quian and Joel Walensky. Carlos Andrés Suarez-Quian will narrate the video. Let's start. The muscles found in the gluteal region and posterior region of the thigh are indispensable for carrying out everyday activities, vital for maintaining a rich and vibrant life. As well, these large muscle masses are necessary for performing activities essential in running and jumping sports that bring much joy to the participants. Important nerves and vessels are found in the region, and clinicians must be cognizant of their paths to avoid life-threatening injuries during routine procedures. Let's start the dissection of the gluteal region in the posterior thigh. As with any area of the body, we start our dissection by removal of the skin and superficial fascia. In the gluteal region, because the underlying structures are relatively large and the superficial fascia is so thick, it is okay to remove the skin and superficial fascia together in one step if you are pressed for time. Removal of the superficial fascia and fat expose the large gluteus maximus muscle and its more anteriorly located gluteus medius, which is seen deep to the strong gluteal fascia. Also observed is the fat contained within the ischial-anal fossa. The anus can serve as an orientation point to demonstrate the midline of the cadaver. As the dissection progresses, it is very easy to become disoriented as to what structures are located midline versus laterally, especially the cadaver has been bisected. The ischial-anal fossa is a fat-filled space that facilitates distension of the rectum and anal canal when they are filled with stool. In addition, on its lateral wall, the pudendal nerve and accompanying vessels are found. The pudendal nerve will give rise to the inferior rectal nerve, the only nerve found within the ischial-anal fossa proper. The pudendal nerve innervates the perineum and is sometimes anesthetized during labor and delivery prior to entering the fossa. The ischial tuberosity is the area of the pelvis on which we sit. It can be palpated in the cadaver for orientation purposes. The entire gluteus medius is revealed by reflecting the gluteus maximus. As the gluteus maximus is reflected, the inferior gluteal neurovascular bundle is revealed on the deep side of the muscle. This bundle contains the nerve and vessels that supply the muscle. Further reflection of the gluteus maximus reveals that the inferior gluteal neurovascular bundle emerges inferior to another muscle of the gluteal region, the piriformis muscle. Reflection of the gluteus maximus is difficult because part of its origin is from the sacrotuberous ligament, a ligament that helps to stabilize the hip bone when we are upright. As its name implies, the sacrotuberous ligament extends from the ischial tuberosity to the sacrum. With complete reflection of the gluteus maximus, the very large sciatic nerve is revealed, emerging through the greater sciatic foramen, inferior to the piriformis muscle. The sciatic nerve will often be found midway between the ischial tuberosity and the greater trochanter. The sciatic nerve has now been fully exposed, emerging from the greater sciatic foramen. Again, note its relative position approximately midway between the ischial tuberosity and greater trochanter. Remember these locations for when you are thinking of administering an intramuscular injection into the gluteal region. Always think upper lateral quadrant of the gluteal region to avoid injuring the sciatic nerve. When the sacrotuberous ligament is reflected, the pudendal nerve and internal pudendal vessels can be seen emerging from the pelvis, also through the greater sciatic foramen. Realize that the pudendal nerve and accompanying vessels travel sandwiched by the sacrotuberous ligament that is now reflected and the sacrospinous ligament that is now revealed. The sacrospinous ligament takes its origin from the ischial spine and is this bony prominence that can be palpated from the vagina to serve as the point to aim the needle to deliver anesthesia when performing a pudendal block during delivery. The needle is inserted through the vagina and is angled laterally aiming for this location. Remember, the pudendal block must be performed bilaterally. Pudendal nerves on both sides of the patient must be anesthetized. Retraction of the sciatic nerve now reveals the smaller muscles of this region. We can now see the tendon of the obturator internus muscle, bordered superiorly by the superior gemellus muscle and inferiorly by the inferior gemellus muscle. All these muscles function to externally rotate the thigh. The last of these external rotators that are observed at this time is a quadratus femoris muscle. The tendon of the obturator internus muscle is lifted to reveal that it also traverses the greater sciatic foramen because the origin of this muscle is along the internal aspect of the ilium. In order to reveal the gluteus minimus, the gluteus medius must be reflected. This is done by instilling a tool deep to the medius as shown, putting tension on the fibers of the medius, and cutting the muscle's origin from the ilium as shown in the next slide. The gluteus minimus lies directly against the external surface of the ilium and functions with the medius to abduct the thigh. The gluteus medius and minimus are supplied by the superior gluteal nerves and vessels, which emerge from the greater sciatic foramen superior to the piriformis muscle. Injury to this nerve will result in a positive Trendelenburg sign, in which the hip drops opposite to the side of the injured nerve when the foot is lifted on the same side to take a step. The reason for this is that the abduction of the hip by the gluteus medius and minimus on the injured side cannot be performed. Hence, the hip falls to the uninjured side due to gravity and absence of support. This too has been described at times as a Trendelenburg waddle. Rotating the lower limb some allows us to examine the lateral aspect of the thigh, where the tensor fascia lata muscle is located. The tensor fascia lata muscle is also considered part of the gluteal group of muscles because it is innervated by the superior gluteal nerve. This muscle is encased within the deep fascia of the thigh and acts to tense the iliotibial tract. This action helps maintain knee extension and thereby erect posture. Moving inferiorly from the gluteal region leads us to the posterior thigh. And, as with other regions, the first step is to remove the deep fascia. Here, as you can see, the deep fascia of the thigh is rather prominent. And removal of the deep fascia exposes the hamstring muscles. The hamstring muscles are three muscles that originate from a common tendon that attaches to the ischial tuberosity. The three muscles are the biceps femoris, the semimembranosus, and the semitendinosus. All three of these muscles act primarily to extend the thigh at the hip, but also can flex the knee. Note also that the vastus lateralis is well seen from this posterior view because it largely originates from the back of the femur. Not knowing this can result in a mistake on a practical anatomy exam. The tendon of origin of the hamstrings is shown clearly in this image. Note that there is a short head of the biceps femoris that originates from the femur that can flex the knee but cannot act at the hip. The sciatic nerve, meanwhile, continues inferiorly. In this specimen, the nerve does not split until it reaches the apex of the popliteal fossa. In other specimens, it is not uncommon for the nerve to split much higher up, including as high as within the pelvis itself. Distally, the semitendinosus and semimembranosus are easy to differentiate. The tendinosus is named as such because it terminates in a long, thin tendon, whereas the membranosus remains fleshy for most of its length. Also, here we can see the sciatic nerve bifurcating into its two components, a tibial nerve and a common fibular nerve. Moving on to the blood supply, the femoral vessels pass from the anterior thigh to the posterior thigh through the adductor hiatus. And as they do, they change names and become the popliteal vessels. Note also that the common fibular nerve becomes subcutaneous as it crosses the neck of the fibula and is subject to injury at this location. This sometimes occurs during ice hockey when the blade of an opponent's skate transects the nerve. The patient will then have a foot drop as he will not be able to dorsiflex his foot. In this image also, the lateral and medial head to the gastrocnemius muscles are now labeled to demonstrate the inferior boundary of the popliteal fossa. Further dissection of the back of the knee reveals the popliteus muscle, which is an important external rotator of the thigh during the end of the stance phase of gait. The last step of the dissection is to rotate the thigh and place it in a supine position. We observe the insertions of the upper medial tibia of the sartorius, gracilis, and semitendinosus, which form a three-pronged pattern that is referred to as a pes anterrinus because it resembles a foot of a goose. This now concludes the dissection of the gluteal region in the posterior thigh.